as well. So this is an interesting phenomenon to me, and I'd like to understand it better. So we worked on models to try and do that, because if we can do this, even, let's say, not perfectly, but fairly well, what if we were able to figure out the mechanisms that allow this to happen, and we could do so for a larger chunk of tissue lost in an older guy or gal? That would be a step forward, because we have those folks rolling into the ER every day, as you've seen. So a collaborator of mine, Ken Munioka at Tulane, has done work with the mouse and has shown, this is a little difficult to figure out, but this is a normal mouse digit tip, and this is such a tip amputated at about the level of the amputation you saw in that little girl at a week, and it's starting to regrow a tip, and at 2 weeks you get more bone elongating the tip, and at 3 and 4 weeks then you've got restoration of a fairly normal looking digit. But if you look really closely, you notice the eccrine glands present in the normal digit don't really regenerate. So it's sort of like in the human, it's pretty good, it's better than nothing. It's not perfect. And if you amputate proximal to upstream of the distal interphalangeal joint, the last joint, then you don't get a regenerate, you get a scar, a stump. And this is a clinical picture, if you can use the phrase in mouse speak, of a normal digit and then an amputated pair of digits, one above and one below, and they grow a little shorter, a little curlier, but they regrow, whereas if you amputate proximally, they don't regrow at all. So this is a model that we can work with and help, we think, help understand what happens in the human and see if we can tweak it, if we can stimulate even better regeneration in the mouse, can we translate that to the human? And so Dr. Munioka has looked at molecular markers that are associated with the ability to regenerate, and it turns out that this transcription repressor, MSX1, seems to be associated with the ability to regrow a digit tip after amputation. And what's suggested is that this keeps cells in a sort of a stem-like state in a little niche where they're available for use in the event of an amputation. It's also been shown, though, to promote dedifferentiation in some organisms, and it's associated with regeneration in many regenerating organisms. So it's a fascinating sort of first chink in the armor, if you were going to think about something to look for in humans. In fascinating work by Shannon Oderberg at Utah, he's taken supposedly terminally differentiated mouse myotubes, which are multi-nucleate cells, and exposed them to MSX1, and has shown that they undergo a process called cellularization, where they become mononuclear again and go back to being stem-like in nature and can be driven down different lineages to become bone and cartilage and fat. So, and that's a mammalian cell, so that's remarkable. So this is a mammalian cell that's beginning to function like those regenerating organisms that we've seen before, like the newt. So MSX1 is a good target. So Zeltinger and Holbrook defined a serum-free medium for the culture of human fetal digits, and I came across this paper and I thought, well, this is an interesting area, raises ethical questions, but I see folks who raise clinical challenges. So this work has been extended by our lab, and we've looked at MSX1 expression in the human fetal digit. It's present. It's present in the same location as in the mouse, underneath the nail bed and past the nail fold. And we further found that with tip amputation in culture, first, the digit tip does regrow to some extent, which is remarkable. Since you're just growing in a dish, you don't have the systemic circulation. Second, we found that this MSX1 transcription repressor is either upregulated, meaning the cells at that amputation site begin to express it in greater quantities, or proliferation of cells that already expressed it results in more cells making, therefore, a larger quantity of this substance. Or finally, one possibility is that cells that express it upstream migrate to help rebuild the tip. And so this does look like a molecular marker of, or component of, or candidate for association with a process that looks quite like regeneration in the human. So it's tremendously exciting, and we're working now with several groups, as discussed by Dr. Foy, with this funding we've suddenly been fortunate enough to receive, to see if we can parlay this into the ability to regenerate larger volumes of tissue lost in the adult. And so the cells are interesting to us. Long story short, you can isolate them and culture them and show that they do express MX1 in a dish. So now we may be able to work with these cells and understand better how it is that they do what they do. And so things to think about are then, can you bring about, if you learn how these cells work, looking at the pathways that they follow as they reconstruct a digit tip, can we then add those cytokines, those factors, to a wound, like some of the wounds that you saw, like that stamped off hand, and see if we can actually stimulate regeneration in situ at the wound site. Can you, as another possibility, find cells like that in the adult? We don't know yet. We're funded now to start looking at that, and we're going to track that down very soon. If there is a population of stem-like cells in the adult, can we then use the patient's own digit tip stem cells to help regenerate a digit tip by delivering them to the wound site? Or finally, can you use them in a standard, more and more becoming standard tissue engineering application to seed cells to a scaffold and then rebuild the part sort of in a dish, in an incubator, and then reattach as a different type of transplantation using the patient's own tissues. So we're working on all of these things. A colleague of mine, Dr. Zhang, in the materials science area, has developed scaffolds that we've used on occasion, which involve a biocompatible material derived from crab shell called chitin, and which undergoing various chemical modifications is then called chitosan. And so we've looked at whether digit tip cells will bind to and migrate on chitosan. We've looked at the idea then, you can imagine, this is sort of speculative, but it's where we're pointing our research efforts. Somebody like my calf roper, a population of digit tip stem-like cells that can be culture expanded into numbers suitable for seeding to a scaffold of our choosing, something biocompatible, something the body will accept, not reject, replace with its own cells, which then elaborate their own extracellular matrix, degrade this biocompatible scaffold. You can formulate these things. It's already been done as long as 10 years ago with cow-derived cartilage and bone cells on a fairly simple polyglycolic acid scaffold and implanted into immunocompromised mice. Other researchers have shown you can tissue engineer skin, and you can actually tissue engineer to stratified epithelium, which invites nerve ingrowth. So all of a sudden you put all these things together, which has not yet been done, but there is no reason in today's day and age why it cannot be done. And you can really imagine taking this sort of snap-on digit and making something much more like a living digit from all these different findings from all these different labs. But I must confess, my true interest remains the idea of regrowing the part instead of building it on the back bench and sticking it on. And you say, as I did earlier, the volume of tissue in an arm amputation is too great to expect it to regenerate. But my colleague Ken Munyoka, who's down at Tulane, which is in Louisiana, which are near the bayous, sends me this picture of these apparently adult alligators, one of whom is regrowing a pretty good-sized tail after amputation, which is about the size of my skinny little runner's arm. And so it may not be beyond the pale to imagine that in the right circumstances, with the right stimuli provided by us, based on lab work that a number of people are working on, we could regrow arms. And then I'll bring us full circle and finish up with the idea that even something as simple as carpal tunnel may be looked at in a different way in 10 or 25 or 50 or 100 years. We could poll you on the way out, and you could each come up with your own idea about what regeneration and tissue engineering and sort of the next phase of medicine might involve for carpal tunnel. I can't believe we'll still be taking a knife and cutting people open in 100 years. You could imagine gene therapy to deliver something that would boost the vascular supply to the nerve, or strengthen the nerve against the compressive forces, or loosen the transverse carpal ligament so that there was more space, or any of a number of ideas that you guys could come up with. But I'll close by saying that the future of medicine, I think, is going to be much more regenerative than ablative. And so guys like Hugh and I are going to be looking for work, which is just fine. We have all that we can handle now, and we'd love to watch you guys, who are now the up-and-coming generation, take over and be smarter and do a better job. The future lies in our learning how to use the body's own innate capabilities, directed, stimulated, maximized, optimized, however you choose to say it, as needed for specific conditions. And the fact is that our true regenerative limits are not known. And given a chance, rather than operating all the time, it turns out if you stick a skin graft on the tip of an amputated digit, it stops growing. So if we just leave things alone, things do quite well for themselves. So maybe as we get smarter, we learn to stop intervening so much and see what things are capable of on their own. So I didn't tell you my goal at the start, but I'll tell you my goal now. It's to recruit the next generation of physician scientists, and it turns out that a bunch of you guys are candidates for that, like it or not. And if I have the honor to do so, to train you in clinical and research skills, and then come back here in a decade and hear you guys tell me what I didn't think about and how you're doing something that is so far beyond what I imagined that I just sit there in awe, which I know will happen. And at a minimum, for those of you who don't want to go that route, think about the things we've talked about. We all need your support. Certainly research funding is always welcome, but the idea that you can talk to members of the community or politicians or just sort of have a heightened sense of what's possible and stay involved and be active, because it is your community, and the community of medicine needs the support of the folks we are committed to serve. So we're actually all in this together, and I say your votes, I mean your votes. So more info, ask questions, appointments, etc. Look for me on our department website, and I'll be happy to hear from any of you about anything at any time, including now. And thanks for your time.
One thing we see in trauma patients who we are not able to completely close their abdomen and have to put skin grafts on them is we see them grow new bone. Where they had no bone at all in their abdomen, they'll grow pretty substantial bone, at least as large as a rib, on the edge of where their skin graft meets their native abdominal wall. Can you just comment on that process and if that has any potential?
Yeah, so we were talking about this a little bit earlier. We see that in patients with head trauma as well. For some reason, that seems to change some metabolic pathway so that bone is formed. Heterotopic means in a location that's other than the usual location. And we were talking again about bone morphogenic proteins, which are chemicals which can make bone form in muscle tissue and that sort of thing. But it may be something to do with displacement of the periosteum of the ribs adjacent to the injury site. Often in extremity trauma, there's such an explosive injury to the bone that little particles are sent out into the muscle, and we think that acts as a nidus for, or a source for some of this bone to form. I don't know that anybody yet understands what's going on in head trauma, but it seems to, the metabolic control of bone formation involves calcium and phosphate metabolism, and it's tightly regulated. And I was just talking with a group yesterday about the dozen or so factors that can either upregulate or downregulate bone formation and resorption. So it wouldn't surprise me that there's some sort of metabolic dysfunction due to head trauma that changes the cell function in the region of the injury. And certainly just cutting in that area is going to cause those cells to be responsive in a way that they don't do when they're just sitting there uninjured. That's a long way of saying I really don't know. But I'm fascinated. He told me about that, you know, I guess he was priming me to get ready, and that's as ready as I can be, but I really want to see the x-ray of the guy that he said one of these things grew back as big as a boomerang. So I'd be interested in seeing that.
Being one of the maladies that I see most in people I know, back pain, having to do with discs and things like that, is there a correlation here that someday some of these disc pains and back pains may
I don't
be
do
able to
spine
be
surgery, but if you're asking are there regenerative therapies in the works for back pain, oh yeah. Is that actually the question?
Yeah.
So
Could it be
that's an amazing
translated
area. Yes. So folks are working on tissue engineering the nucleus pulposus, which is the central portion of the disc, and the annulus fibrosus, which is the hard fibrous outer coating that's thought to rupture as we age and squirt out the nucleus pulposus, which presses on the nerve root, which gives you sciatica or worse. And those things are being worked on now. There are already replacement discs available, and those are being looked at as an avenue for tissue engineering applications. Right now, it's